forwards with our day, with our session. Now we have another hot, very, very hot topic. I think every anesthetist have has been involved in this situation. We have Dr. Laila Woc Colburn. She is giving us a lecture on cardio implantable device infection. I would like to say that Dr. Laila is an associate professor of infectious disease, Emory University School of Medicine, Atlanta. Uh, and she's giving us this lecture. Dr. Laila, can you start the lecture, please?
Good afternoon, good evening. Greetings from Atlanta, Georgia. It is always a pleasure to be lecturing for the Mega Learn platform for anesthesiologists. As you know, I'm an infectious disease doctor, and Dr. Ahmed's talk was very interesting for me, especially the post-op, because I have to deal with a lot of community-acquired pneumonia and hospitalization pneumonias because they don't do the incentive spirometer. But anyways, I'll talk to you about cardiac implantable devices. These are pacemakers mostly. And these are the older ones, which still have leads. There's the newer ones who have become leadless, but we'll go through that. I have no disclosures. So the objective of this talk is to kind of describe the epidemiology and prevalence of cardiac device infections, some indications for lead extractions, what you need to have, and review kind of the consensus standardizations of the management, the 2017, that the European as well as the American infectious disease societies go by. So the reason we want to talk about cardio intravascular electric devices is because they're becoming more prominent. You can see here since, from 1993 to 2008, we've seen on the blue line the rate of CIED infections going up, as well as the number of implantations. So you always ask yourself, if we implant more devices, are they becoming more infected, or is the technique that we're using the source of infection that we have? So we see this marked increase and then increase in implantation. And so there's been a couple of things. One is the pre-op bundle of trying to keep the area clean. And then there is the rapid trial, which we'll talk about, where the pocket where this implantable device goes in there, it's coated with antibiotic like minocycline. So we have about a 250,000 infections per year, and that leads to about 157,000 replacements. And you might ask yourself why the replacements are not 250,000. And it has to do that when they're infected and the electrophysiology do their workup again, then they realize that the device might not be needed at that time. So that creates about 30,000 or about 31,000 infections per year. So looking at that, you can look at the difference in incidence in different age as well as sex. When you look at the group that is 50 to 70 years on your right, you'll see that there's the blue line, or I guess periwinkle color, is going up, especially in 2009 to 2015. As you can remember, the data that I presented before just took you to 2007, sorry. And then you can see that in elderly, more than 70 years old, the infections do decrease over time. And there is no discrepancy, and there is between female and male persons that have the device. And then on your left, you're going to see the incidence of CIED infections for every 7 years from 1988 to 2015. It's a Kaplan-Meier curve, and you can see that a year that we had a lot of increase, which is the red line, was between 1995 and 2001. The year of 2009 to 2015, because of the new interactions in maintaining the area, looking at if the device is needed, giving post-op antibiotics while the skin heals, you are going to see that the incidence is less infections over time. But needless to say, we still see them quite a bit. And where do we actually see them? You know, you can see the comorbidities in the CIED patients that tend to be patients who have diabetes, heart failure. Obviously, that's the indication, one of the indications for the pacemaker and defibrillator. And a lot of them also have renal failure. So remember that where the device goes is sometimes the same vein where you need to put the lead, that you can have a catheter and hemodialysis catheter that can interfere and get infected from bacteremias. So the risk factors, if we look at it and we look at each one, we can divide them in patient-related, procedure-related, and micro-related. Patient-related factors is definitely going to be age. As we saw, the age group between 50 and 70 seems to be more likely to get infected. Patients who have chronic disease and have hemodialysis will definitely be out of a higher risk. And it has to do especially with bacteremias because of the dialysis catheters, infected fistulas. And definitely those patients who have immunocompromised immune system with immunosuppressive drugs, the use of steroids. As you know, the longer use the steroids, the healing is not as good. Malignancy, and then other comorbidities like heart failure and COPD. Then we can have, for example, procedure-related factors. So this is where the technique from the EP comes into place. How, if you've had a prior infection, the pocket reintervention, how much damage it is, how much ischemia you do, how much it takes you to change the generator or upgrade. If it develops a hematoma, remember our bacteria love blood, so that's a nice place. And as we know from infections, the longer the procedure is always a risk factor for infection. Of course, if you don't have the experience or you don't have the right places, then of course that is going to play into a plane. And then lack of prophylactic antibiotics. So usually the prophylactic antibiotics that we use are either cefazolin or vancomycin, depending on there. Most like the one that we usually prefer is vancomycin, since when you look at the microbiology, is more staphylococcus as well as Cutibacterium, which cefazolin doesn't have activity against MRSA and Cutibacterium. And then obviously the micro-related factors, highly virulent microbes, Candida, of course, plays a factor into that. So we look at the microbiology trends over in this paper from Hussein et al. From Jack, and it looks at it, you'll see that the majority are going to be gram-positive bacteria. So these are skin bacteria. You're going to have Quagley's negative staph, so that's Staph epidermidis, Staph saprophyticus, ludinensis, and then you're going to have your good old Staph aureus, either MSSA or MRSA, and then we're starting to see more what was formerly known as Propionibacterium acnes, now is called Cutibacterium acnes as part. Fungal infections tend to be very low, and it definitely is an indication, but we do have about 13% who tend to be negative culture. So looking at this, you can see the trends over the years. Quack negative staph is usually the first one. Caps keep pretty good, but one that has been on the rise is more the Enterococcus, either fecalis or faecium. And we do worry about the faecium, definitely, because that's the one that becomes vancomycin resistant. This is from the RAPID study done by Sohail et al. At Mayo Clinic and published in the Journal of American College of Cardiology this year, where they looked at the different frequency of pathogens affecting the pocket as well as the lead. And as we talked, more the envelope, what we saw was gram-positive. So Staph aureus, ludinensis, epidermidis, and then other gram-positive like Cutibacterium, acne corynebacterium species. Less likely we'll see the gram-negative, and definitely you can have Candida albicans, especially in those patients who have diabetes, uncontrolled diabetes. And the graph on the right, it shows you pocket infections versus systemic. And this is the question that comes to us from electrophysiology. If it's just a pocket infection, because that will determine how long we treat, versus a systemic infection, which will require IV antibiotics and definitely a 4 to 6 week treatment. So we can classify, as you can heard, is either superficial or deep infection. So superficial is your pocket subcutaneous tissue. You can have sometimes an erosion, depends how long it takes. Sometimes patients come here with the pacemaker or the defibrillator already coming out, or some of them as they were taking the showers, because the skin gets too thin, it just pops out, and then they just pick it up from the shower floor and then put it back on. So that, things, asking those questions actually help us differentiate between superficial and deep infection. And definitely, we want to swab that part perioperatively. The part of the swab cultures is because 40% can lead to a delayed infection, and you really want to know that, because you don't want to leave the leads there and cause that. So apart from the anesthesiology is part of it is making sure the antibiotics are given perioperatively on time, but also making sure that the cardiologists or the electrophysiologists actually acquire cultures when needed. So this is from a review from 2007, and you can see different incisions here. You see something that doesn't look infected, it is well healing, but there is a little bit of a bulging, and when you touched it, there was fluid underneath. And then things that can be a little bit more dramatic, like B, C, and D, where you actually see the pacemaker coming off, or sometimes the leads comes off, and then that's kind of an easy diagnosis that this is going to be more of a systemic infection than something that is superficial or a deep pocket infection. So they might present with fever, malaise, or chills. The area might have erythema. You might express pus and drainage out of it. Laboratory findings usually don't help us a lot. Some might have experienced leukocytosis, anemia, but the most important one is the blood cultures. If you have blood cultures that are positive, that already gets you a category of systemic disease. So if we look, so let's take the case. We have a 71-year-old male who presents with fevers and chills, pleuritic chest pain of 4 days. He has a permanent pacemaker that was implanted 15 months ago for 6 sinus syndromes and syncope. He's febrile, he's tachycardic, he's not hypotensive. The general pocket is, without warm and erythema. This is what they tell you in the emergency department, but it's covered with a gauze. They do hear scatter rhonchi and pleural rub on the right base, but no murmur or cutaneous findings associated with infective endocarditis. They do consult infectious disease, and we unwrap the gauze, and this is what we see there. We see this area that, it wasn't clear. It's a granuloma. This usually tells us that it's a non-healing part. It's kind of the top of the iceberg, and this granuloma underneath that causes, you can see that there's a little bit of secretion. So I usually, if things are wrapped or I have a gauze on top of it, I make it a habit of unwrapping it just to make sure that everything has been taken care of on part of the exam. So the diagnostic workup when you have a suspected CIED is that preoperatively you want to make sure you have a CBC, a complete blood count. SED rate is a plus and minus. I'm more of the protein C reactive. And the reason I say plus and minus on the SED rate, it varies a lot with age and depending on depends on the albumin level and age that is going to. So the protein C reactive definitely helps. Procalcitonin has been used as a septic biomarker to differentiate between viral or infectious. And when you have a pacemaker that is being eroded, that definitely is going to be either infectious or fungal. It's not going to be viral. So you can save your patient some money just by not ordering a set rate and a procalcitonin level. And that's my personal opinion. But definitely obtain 2 blood cultures. You really want to have the blood cultures included fungal. And if it's been a long time, I usually order AFB for those rapid growers, mycobacterial diseases that we sometimes have, and we're seeing more and more. We can have culture negative, just like we have culture negative endocarditis, we can have culture negative device infections, and we'll see how we address those. And definitely a TEE, and this is the part where anesthesiology comes in, has to be performed in all of these patients over a transthoracic, because you want to detect those valvular vegetations, the extension of the infection, and abscess and the lead vegetation. And why is this important is because that's how you're going to prepare for lead extractions. So if you're only changing the chamber, should say it's not a difficult procedure, but if you're going to do lead extraction, you do have to have a backup of a cardiothoracic team that is ready to go. Because sometimes when you extract the leads, you use laser and you can heat too much and then make micro perforations on the myocardium or big perforations. But it also makes a difference if you have a perivalvular abscess. It's probably the best that, having an exchange of the valves and at the same time the procedure than just changing the lead. So it is going to be used for stratification and to plan what you're going to do with your patient. Then post-op, post-op, you're intraoperatively, you're going to swab the pocket, send that to microbiology for fungal, bacteria, and AFB. We also want to do testing. In some places, they extract it. We can do sonification. This is also done sometimes with prosthetic joints. They put it in a sterile jar with sterile saline, and then you sonicate it. And the idea is to gather more. You can scan the QR code to hear more about this on the diagnostic workup on the work from Dr. Suhail et al. From the Mayo Clinic on a review paper from 2018. So continuing to our case, we did blood cultures, and there were 3 sets out of 3 were positive at 24 hours for MRSA. Chest x-ray showed nodules and pleural-based lesions. Remember, he had this rub. So definitely septic emboli. So you are already talking about here a complicated MRSA bacteremia that has thrown septic emboli. You're already looking at a 6-week period of antibiotic. They did a transthoracic because it was fast at that time, because the patient was not prepared to do a TE. And you can see where the arrow is, where the lead is, and that's where it was showing this echogenic mobile mass on the tricuspid valve part of it. And then the question was, is the lead infected or not? So it's sometimes hard to know how to do this. So in 2017, some experts got together to find, a consensus. So they're not guidelines, but they're consensus of cardiovascular or implantable electrical device for lead management. And here is the QR code for those guidelines. And you can see from a picture for here, it actually walks you through very easily. You suspect that you have pocket or systemic, you do your blood cultures, always get an infectious disease consult. If positive blood cultures or prior antibiotic treatment, maybe they went to see their PCP and decided to give him something like cephalexin or minocycline, always do your TE. And what you're looking for is a valve vegetation, a lead vegetation. If you have a valve and a lead, that's kind of the easier part. Depending on your bacteria, you remove the CIED and you do antibiotics. Obviously, the question is, when can you reimplant the cardiovascular? So one is, do you actually need to reimplant it? And then you can reimplant once blood cultures are negative at 72 hours or longer, depending on the clinical scenario, depending on also the type of bacteria or pathogen that you have. A negative TE is concerning, as well as a culture negative is concerning. This might be, that's too early, but the new technology is using PET CTs to order to be more definitive, because a negative TE you actually are sometimes missing. You might consider, if your PET CT and your T is negative and your blood cultures clear quickly, and depending on the bacteria, you might just say keep the device and not remove it. When would be that? When there is definitely, you need removal with a fungal, removal with multi-drug resistant organisms, and definitely with any of the staphylococcus. You might be able to retain if you have Cutibacterium, but in the near future, you have to think about replacing. Let's say you have negative blood cultures, you do a TE because you're still concerned. It is negative. You look if it's you have evidence of pocket infection. There is none. There is no erythema. There is no discharge. Your culture is negative. You just observe. If the pocket is positive, or the pacemaker was out, then you remove it and you give 2 weeks of antibiotics, and usually the antibiotic of choice that I use is minocycline. Here is if you have bacteremia without evidence of CIED. So this is basically, you can, you've taken out the removable sources, you looked at the lung, you look at the abscesses, you don't know if your CIED got seeded. But again, the pathogen matters. If you're going to have gram-positive, Staph aureus, Staph epidermidis, coagulase negative Staph, propionibacterium, or fungal, the CIED comes off. Things that we can treat through are streps, and even enterococcus if it's not a vancomycin resistant one, and gram-negative bacteria we observe, and you can keep it as long as you have an oral option and it's not multi-drug resistant. When do we have that? So when do you definitely have? So we talk definitely with bacteria, lead endocarditis, valvular endocarditis, abscess, erosions, draining sinuses, staph bacteremias, and sometimes gram-negative bacteremia if they're persistent or they're multi-drug resistant bacteria. So management here in the background, you'll see a lead that has a nice big mobile vegetation that is coming. So you actually want to extract all the hardware. And this is always a debate that we have with EP and cardiology, especially in those patients who are very sick. It is, can the leads be extracted? Can the patient go through surgery and come out of the anesthesia and still be okay? And that's going to dictate if we can have an antibiotic that can help, that if we have an oral antibiotic that we can suppress the infection until that patient is good enough to have a way of extracting it. If not, the lead comes out as well. And then you want to try to, if it's on the left, usually on the left, you'll reimplant it on a new side, which is on the right. Hopefully there's no stenosis from previous lines and things like that. This is courtesy of Dr. Eliseo Nasseri. He's at Houston Methodist. So this is a patient that we worked together. You can see that, and the indication was lead extractions because he had positive blood cultures as well as a positive echo. It's done under fluoroscopy. You can see the transesophageal device, and you'll see that the leads are being taken out. It's usually like a hose that goes in. It does it's like what I call a rotor-rooter, extracts it out very quickly. You have a cardiothoracic team on standby, and this is what the lead looked like. And you can see that the lead had this smudge as well as this kind of embolized at the tips around it. This is part of the biofilm where the bacteria reside and will continue to grow. So what happens if you have negative cultures or inconclusive data? So that's where, the molecular imaging is coming into play. We've try to use tag white cells where we do iridium scans but they tend to be negative. So the new thing is to do PET CT scans where you have an uptake. You'll see where the pocket is. You'll see if the valve is inflected. You'll see if there's outflow, if the cannula is infected, especially in LVADs. You'll see if there is metastasis of the bacteria, and it actually helps you identify a lot of central infections, and it has a good negative predictive value if it doesn't light up that you have no infection at that time. If you're into podcasts, there's the febrile podcast done by the fellows at Beth Dickonis in Massachusetts, and they had an overview on aortic graft infections with Dr. Vijan, and this is an overview of nuclear medicine studies. And so you can see you start with a tag white cell, has high specificity, but is very labor intensive and the sensitivity lacks. If it's positive, it's positive. If it is negative, it's not going to help you. Then you do the PET CT. It's highly sensitive, earlier diagnosis, assess extracardiac infection if you have metastasis in the lumbar area in the leads, but you can have false positives due to inflammation. You can use that with a SPECT. So this is gamma cameras detect gamma emitting radioisotope. It's less expensive than the PET. It helps you for coronary disease and looking at osteomyelitis, but really doesn't help you to look for cardiac infections. And then so if you tell me which is the one I prefer, and it's what we have tried to push, is a lot to use a cardiac PET CT in order to know if you have to do a major operation or it's just more of a simpler lead extraction, and how extensive the infection is. So in summary, you need blood cultures. You need, if they're positive, you do a TE. Remember to have cultures from pocket, the lead tips when it comes out of removal. Everything that is gram positive and candida has to be removed. If not, it comes to bite you. If it's only a pocket infection, oral, like, depending on which is the bacterial, 10 to 14 days. Bloodstream infections, if it's Staph aureus, is definitely going to be 4 weeks. If it has metastasis, meaning septic emboli, then it's 6 weeks as per our endocarditis guidelines. And then the part is that they'll ask you, well, do you need to reimplant it? And the idea is that you do the EP studies, and maybe you don't need to reimplant it. So that's the easy one, because I don't have to think too much about it. But let's say you do. So you need 172 hours of negative blood culture. So if you extract the leads on Monday, the first negative set of cultures will be on Tuesday. So by Friday, you know if you can put the device or not. Obviously, if the patient needs pacing, that patient is going to be on an ICU until you are able to do that, or a step down. If you reimplant, you want to do it in the contralateral side. If there's endocarditis, it's usually 14 days after original removal with negative cultures. And antibiotic prophylaxis as an hour before implantation. We do, as I said, if because of the abundance of the gram positive, we go with vancomycin, unless you're you have something more specific than that. And with that, I thank you. And if you scan the QR code, you'll be able to have this presentation for yourself. Thank you so much.
Thank you very much, Dr. Laila. It was very comprehensive, up-to-date lecture. Thank you for that. We have just one question. I'll try to, I'll ask the question and then try to go through it. The question is from Dr. Muhammad Suleiman. He's asking, if you have a patient who needs a central venous catheter and he has a cardio implantable electrical device, any precautions if the device, or difference between if the device is clean or infected?
So if you need a central, so first, I guess the way I would address it in real life is, do I have negative cultures or not?
Mm-hmm.
If I have positive cultures, which happens sometimes, that we take off the lines, I would put, if the device is on the left, I'll put a right IJ. So something that is temporary that I can come out, but it's still enough to perfuse. I would not place a peripheral inserted like a PICC line or, a
Above cap or
hemodialysis.
any.
Yeah, yeah. And then if there's no way on there, of course, the place that I less likely I recommend, but it's sometimes the place we go is a femoral line, knowing with the caveat. If it's negative cultures, even if they're positive and you don't have access, you can put this something that is something that is transitory, that the patient is not going to go through there. And then definitely removal of the device and looking for other places where the infection, where this comes more into play. And I think this is where the question might be, is in our dialysis patients, where we have very few dialysis access to the patients, because they've had a lot of lines put in. And so they makes it, we require a line holiday. It makes it a little harder with staph bacteremia. So what we do is we dialyze the patient, give the vancomycin, it stays there, get a repeat culture at 24 hours. Hopefully that will start clearing it up and then go from there. So I hope that answers the question.
Yes, I think this is what is meant from the question. Yes, Dr. Mohammed, thanking you very much. No more questions from our side. Thank you, Dr. Laila. Thank you, Dr. Ahmed. It has been like a very interesting, fruitful day.